care together. This session focuses on practical strategies to address these challenges, enhance early detection, and improve access to quality care. Here we have eminent panelists who will discuss the latest advancements in women's care treatment of cancer, including targeted therapies and immunotherapies gaining traction in India. And for this, we have the conveners, Mr. Raj Gore, co-lead FICCI Task Force on Cancer Care and CEO, Healthcare Global Enterprises Limited, HCG. We welcome you, sir. We welcome Mr. Vineet Gupta, co-lead FICCI Task Force on Cancer Care and Head Government Affairs, Siemens Healthineers. Welcome, sir. Okay, you taking over? Okay, we'd like to welcome the moderator, Ms. Srimay Chakraborty, Partner, Healthcare Services, EY Parthenon. Welcome, ma'am. We have with us Ms. Malti Sachdev, Senior Vice President and Head, Varian India and Territories, Siemens Healthcare. We welcome you, ma'am. Mr. Praveen Akinepalli, Business Unit Head, Oncology, AstraZeneca India. Welcome, sir. Mr. Shankar Shishadri, Vice President, India Subcontinent, Electa. Welcome, sir. And Dr. Dinesh Madhavan, President, Group Oncology and International, Apollo Hospitals is also here. We welcome you, sir. And now I pass on my baton to Ms. Srimay. You can take over. As suggested, we request Mr. Raj Gore to give the opening remarks as well.
Thank you. First of all, thank you all of you for joining us for this session. Would like to thank all the esteemed panelists and friends for being here. They've been integral part of our entire journey of Cancer Task Force, which we constituted in October, in actually 2022. As all of you know, global cancer incidence is rising at an alarming level, and India is no exception to that. What makes it complicated for India is the fact that most of our patients, more than 2/3 of our patients, get diagnosed in advanced stages, and therefore our mortality to incident ratio is much worse compared to other countries. We started our journey with a multi-stakeholder cancer task force in 22 with an aim to map India's entire cancer scenario. Incidence, regional nuances, demand-supply gaps on every front, infrastructure, treatment availability, talent, and what we need to do to address those gaps. It was this comprehensive report which EY, our knowledge partner, contributed significantly. A very well-researched, well-structured report was launched by Honorable Vice President in 22 FICCI Heal. Post that, we as a task force decided that if we as a country have to overcome this magnitude of challenge, we need to actually socialize this report across India amongst all stakeholders to create a common shared understanding of the magnitude of the problem and the task that we have in front of us to address it. Under the aegis of Ministry of Health and Family Welfare, we have done so far 5 regional roundtables conferences, starting with Ahmedabad for Western India states, Bangalore for Southern India, then we went to East, Bhubaneswar, Jaipur, and lastly in Shillong, covering Northeast states. It was amazing to see the response. We had hospital representation, private, public sector, teaching hospitals. We had industry participation, pharma companies, medical equipment companies, diagnostic companies. We had more important stakeholders in terms of policy making, Ministry of Health, Ministry of Finance, Ministry of Medical Education, politicians, as well as key bureaucrats who are going to influence the policy making. NGOs who work for the cause of cancers, patient advocacy groups, startups, And the time spent by everyone at each regional roundtable, the deliberation, the quality of suggestions was just amazing. What we did out of that is we created a comprehensive compendium of all the recommendations that came from bottom up in all these conversations. Again, EY, Srimai helped us to create a document which was launched yesterday, published yesterday. I request all of you to have a look at it. It's pretty comprehensive. With that done, we felt that going forward as a next step, we should focus on women's cancer in India. Now, why? For several right reasons. First, I think last year, more women were diagnosed with cancer than men. Every 8 minutes, one woman loses life to cervical cancer. Out of 2 newly diagnosed women breast cancer patients, 1 loses life in India because of various issues in the entire chain. But it's not just about that. While India is making progress in addressing matters of gender equality, gender disparity, I think there is a lot that needs to be done in front of, in the field of healthcare. We know that women more than men lack the information and power to make the right decision about their cancer care. We know now that women more than men face financial catastrophe and therefore dire consequences to their families because of cancer treatment. We know that average inpatient expenditure on women is substantially lower than on men in India. And we know that more families use less financial distress financing on women than men. This has to change. The time has come to talk about this and change this, because India, our Bharat, will have no chance to become Swasth and Vikasit without Sashakt Nari. And with that, we'll start this conversation. I would like to hand it over to Srimai to give an overview of women's cancer scenario in India.
Thanks a lot, Raj, for setting the context and your opening remarks. Before we get into the presentation, we get into the panel discussion for today, we'd just like to share a couple of, I would say, key data points with respect to cancer, specifically among women in India, which just can act as a sort of a backdrop to the panel discussion which we are going to have. So I think just a key set of data points here which we wanted to highlight is 17 lakhs is the total number of new cancer cases as of 2020 as seen by the government reports. In that, about 51% is women specific cancers, so close to about 8.5 to 9 lakh new cases every year in 2020 was the number of cases reported amongst women, and this puts India among the third country just after China and very close to the US when it comes to the number of new cases among women which is getting reported from a cancer perspective. And this not only is the burden quite a significant number, it's also growing at a rate of close to almost 7% on an average, which again is a growth rate which is quite steep when we look at some of the other countries. An important point to highlight over here, and this pie chart actually breaks down this cancer incidence by type of organ. 3 organ types: breast, cervical and ovarian. These typically constitute 50% of the total number of women specific cancers which we see, and these are very, very specific organ types when it comes to women cancers, and individually these 2 of them, breast and ovarian, are growing faster than the average at about 8 to 10 odd percent. We are seeing some improvements when it comes to cervical cancer, but still the disease burden is quite alarmingly high. And while this is the national aggregate, if we look at the breakdown of this by different states, we don't see any of the states falling short when it comes to incidence. Yes, Possibly the rate of reporting in southern India is better, and therefore we do see slightly higher incidence in the southern part of India, specifically for breast and ovary. But the north and the west, as well as the northeast, are following suit. Important to also highlight that cervical cancer, it's I would say the prevalence is quite the same across a lot of the states in the country. So that's an important factor to keep in mind when we take any of the decisions with respect to policies targeting specific organs. This, I think, is an important data point, and it alludes back to what Raj was specifically mentioning with respect to the severity of the issue when it comes to specifically women's cancer. The graph here on the left side actually shows the age-wise mortality among men and women due to cancer. Important to note here is that between the age of about 20 to 59, the proportion of women dying due to cancer is seen to be higher than in comparison to men, which clearly is alluding back to the fact that possibly the amount of importance which women as a part of the society get in the decision making with respect to treatment for cancer is not the same relative to men, especially in the prime of their age. So that's an important metric from, and this is all government data which supports the fact that there is a certain amount of neglect when it comes to women. What the graph on the right hand side highlights is that the important metric for outcome, which is mortality to incidence, which we typically use to measure what is the quality of treatment, what is the quality of results which we are seeing in the country across all the three key organ types, whether it's breast, cervical or ovary. The mortality to incidence ratio is actually worse off, again in comparison to some of the countries like China, US and UK. So there is need to actually focus in a very deep manner to look at what are some of the reasons why our mortality to incidence ratio are worse off and what could be done to address that. And one of the key reasons which is shown by the chart below, which supports this fact of a worse MI ratio, is the stage of detection. In fact, if you see the graph both for breast as for cervical, not more than 30-35% of the total number of cases in our country are seen at the stage 1 or stage 2 stage of the disease, which is a very important indicator with respect to the ability to actually treat some of these cancers, whereas that number would be significantly higher, 40%, 50%, 60-70% in the case of some of the other countries which we are seeing in this plot. Now, it's a busy slide, but just a couple of data points on this slide. It just highlights some of the risk factors which are typically associated with cancer. It has data in terms of prevalence of tobacco usage, alcohol usage, obesity. All of these three factors research highlights are factors which contributes towards cancer as a disease. And we are seeing that in a lot of cases this is growing, and factors like both your obesity and some of the other factors, women are actually worse off in some of the states compared to men. So these risk factors worsening, supplemented by increasing pollution, changing in the entire socioeconomic structure with more women working, age of marriage increasing, age of first childbirth increasing. A lot of these factors are actually resulting into becoming drivers for the women becoming more susceptible when it comes to the risk of cancer. Unfortunately, what also some of the surveys actually highlight is that the awareness which is there among women with respect to these risk factors, with respect to even what is basics about breast cancer, cervical cancer, that's not more than 50-60% when it comes to awareness levels done by limited surveys in the country. So it's very important to understand first of all what is the gravity of these risk factors, how are they worsening, and then link it back to how we can take preventive measures to gradually start reducing the disease burden for the country. Just a couple of points highlighted over here. I think in addition to some of these risk factors which are lifestyle related, There is also an important risk factor, which is the prevalence of HPV, which is associated with cervical cancer, and we've seen that the disease burden of that is quite high. While today we do have the benefit of vaccines available, and they are indigenous, they are possibly at 1/10 the price, but still it has not become a part of our national immunization program. So that's one of the key, I would say, drivers for prevention, which can be thought about and looked up on in a very, very intense manner going forward. In addition to that, while there is a lot of work which has happened to create awareness regarding tobacco, there are a lot of measures taken by the government to also make it slightly punitive with higher taxation, etc. We are not seeing the same kind of interventions coming with respect to some of the other areas, factors which can drive obesity, and some of the NCDs, like for example, food which is high sugar content, food which is junk. A lot of countries globally have taken measures to possibly reduce the usage of these kind of items. Taxation of high sugar content products is a norm in a lot of these countries, but we are not really seeing that in a significant way from an Indian context. Moving on, I think this was all about the disease burden and about awareness, prevention, etc. One of the factors for late stage detection is, and this is true, it's not just a women's specific agenda, it's true for even some of the diseases or some of the organs which impact men, that the screening program, which is a national screening program which is there in the country, which focuses on 3 types of cancers: breast, cervical and oral. The penetration of that is very, very dismal. It's not more than about 1 to 2% across both oral, rural and urban areas. There is a lot of gap with respect to the infrastructure, with respect to the workforce available, and there's also gaps in the entire referral mechanism to ensure that once screened and found positive, they are put on to the next level of advanced diagnostics. So that's a good intervention taken by the government. However, the penetration of that is still significantly lacking, and interventions are required to drive that up. And here some of the metrics, when we look at the penetration of screening compared to some of the global benchmarks, India falls significantly short. While this was all about screening and detection, I think the other factor which has a significant impact when it comes to outcomes is the availability of the entire full suite of services, which we call comprehensive cancer care. And I think this is a factor which is quite known to a lot of us. We have highlighted this over the last 2 years in our FICCI work. That not more than 175 of the total districts in the country actually have access to comprehensive cancer care. While the southern districts, southern states, some of the western states do very well, more than maybe 50% coverage of districts with respect to comprehensive cancer care centers, but way to go significantly for the eastern, northeastern as well as the northern part of the countries. And also very important to highlight that more than close to almost 40-50% of all these centers are actually located in the metro cities, which again creates a significant burden, especially for the tier 1, tier 2 cities, from where patients have to actually travel, which is again an important factor when it comes to women, that will the families be supporting to actually help them traverse that journey, come to the metro cities and take up the most advanced and the best treatment options which are available for them. I think very quickly on affordability, I think this chart just talks about, this was some data which we had collected some time back with respect to the cost of treatment in private setups, and what this really shows that if the stage of detection is early, in the stage 1 or 2, even then the cost of treatment can go up to anywhere between 4 to 8 lakhs. And as the stage of detection increases, and with the advanced treatments, if they are put into place, the treatment cost can go anywhere up to about 8 to 25 lakhs. And in both scenarios, we do see that even in stage 1, stage 2, anywhere between 40 to 60% would actually be medical oncology, followed by the other modes of treatment. That remains true even in stage 3 and stage 4. So it just talks about the fact that, how high could the treatment cost be, and how important some of the therapies are with respect to treating some of these cancers like breast and cervical. Now, just keeping this cost of treatment in the backdrop, we just wanted to highlight that therefore how many people could actually afford this kind of cost of treatment when it comes to the Indian context. And if you first see the pyramid at the bottom, it just talks about the breakup of the entire nation with respect to household income, and it just shows that that's not more than 20-25% of the population who can actually afford an 8 lakh treatment, which is the lower end of the spectrum. And if you are looking at a 20-25 lakh kind of a spend, it's just maybe the top 10-15% of the population. Yes, while the top chart just does show that there is good insurance penetration in the country, both with the support of the government as well as the private insurance penetration increasing post-COVID. We still see that there is possibly close to about a 40-45% uncovered population today, likely to go down to about 20-30% going forward. But there is the need to increase coverage when it comes to the population for giving access to treatment for cancer. Now, while these coverages are available when it comes to insurance policies, what we also did was that we just quickly looked at the various insurance schemes which are there in the country across the states from a government perspective, and it shows that if you look at the specific treatment options available for cancers, a lot of these schemes don't cover things like immunotherapy. It does not cover your genomic sequencing. There are quite a few of the MABs, which are important medical oncology drugs, which are not covered by these schemes. So there is a lot of variation across different schemes, and the states are operating with these schemes, which clearly is one of the factors which will significantly impact outcomes, and it will result in differential outcomes across the different states of the country. This, I think, just also highlights the same fact that while even if we look at the coverage, the amount which the government actually reimburses, while the policy states that it's a 5 lakh coverage for individuals, but ultimately the government will reimburse specific procedures. Individual procedures across different state schemes do not have the same reimbursement rate, which also talks about the fact that what is the kind of differential which is there in terms of the type of providers who will come forward for taking up these schemes and providing service to the patients across the different states of the country. I think that sets the context. Just last one page where we therefore wanted to summarize that awareness, prevention, detection, access and affordability. I think these are the 4 important pillars which remains true and is important, not just for overall cancer, but specifically keeping women's cancer in context. And our panel discussion will delve on some of these topics as we go forward. I think that is the end of the presentation, and I'll just take this opportunity to introduce our esteemed speakers. We have with us today Raj Gore, co-lead FICCI Task Force on Cancer Care and CEO Healthcare Global Enterprises Limited. Ms. Malti Sajdev, Senior Managing Director, Varian. Mr. Praveen Akinenipalli, Business Unit Head, Oncology, AstraZeneca, India. Mr. Shankar Sheshadri, Vice President, Indian Subcontinent, Electa. And Dr. Dinesh Madhavan, President, Group Oncology and International, Apollo Hospitals. We'll start the discussion. And I think I'll start the discussion with you, Raj. We talked about women-specific cancer and the fact that there is also a certain high cost attached to it, but that cost also comes with the fact that there is significant advancements which have happened in the treatments available today, whether it's NGS, whether it's immunotherapy, and also the possibility of outcomes has improved with those treatments available. But given this, there is still 2 important gaps which need to be addressed. One is in terms of access to these treatments in tier 2 and tier 3 cities, and 2 is in terms of awareness with respect to these treatments. So what are the ways in which we can universalize the awareness about these treatment options among women in India? And the second one is that, in your view, what are some of the 2 or 3 advanced treatment options which are today a must when it comes to be included in some of the reimbursement schemes which we have?
Thank you. Over the last decade or so, with multidisciplinary approach, availability of multimodal treatment, advancement in molecular diagnostic genomic testing, and based on that, personalized and precise treatment with targeted therapies and immunotherapies, we've been able to improve outcomes in all women's cancers. We saw earlier in Shrimai's slide that, for breast, for cervical, we can reduce our mortality to incidence ratio by almost half compared to some of the other countries. On ovarian cancer, we can reduce it by another 10%. That's lot of lives that we can save, which we don't have to lose. But I think the challenges when you go away from urban area, big cities, is the lack of awareness among women and among families who support women to seek these advanced options. I think the first thing we need to do is, we know that more than 50% of oncology patients are actually diagnosed by non-oncologists at a first touch point. Oncology is such a rapidly evolving field that it's hard enough for oncologists to keep pace with it, forget about non-oncologists. So first, I think primary caregivers, whether it's GPs, whether it's non-oncologists, in some places they are nurses, paramedicals, Ayush doctors, ASHA workers. I think we need to engage them, involve them, and update them on how outcomes have improved. So at a first touch point, at first counseling, there is an awareness among women that there is hope, that they should fight back, that they should seek advanced treatment, and where they can seek advanced treatment. So engaging that first touch point of care providers is the first thing. Second, India has a good track record in creating public education awareness campaigns. Government has done for, various health topics. I think time has come to, create such public education campaigns in creating awareness about all aspects of cancer, actually. Risk factors, prevention, diagnosis, early detection, and availability of treatment options and improvement in outcomes. Third, India is the second largest internet economy. The rural data consumption, is higher than urban data consumption, especially in vernacular. I think we should use that digital platforms, whether it's social media, apps, etc., to engage, women directly with regional languages, with cultural nuances, to spread awareness about that. Last, there are a lot of good intentioned NGOs and advocacy groups and women's group who we need to target to create, awareness about, that cancer can be conquered, you can live longer with a better quality of life. So that's on awareness front. Coming to your second question, the good part in India is, in last 20 years, we have now, with introduction of various state schemes and government schemes and, more private insurance coverage, more than half of India is under some form of insurance. But that's, and we have about 2/3 of our hospitals in tier 2, tier 3 cities, and the only reason why we are able to run, our hospitals viably, scalably, replicably is because of the government schemes, right? However, I think that's a starting point, right? The fact that we have created about 2.5 to 5 lakh cover for families which wouldn't have had option to access good quality healthcare is a good starting point. But today our insurance system, public insurance system, is based on financial limits. right? First, these limits are same for all specialties. Cancer is unique. Cancer is not episodal. It's multiple, admissions or outpatient treatments. It goes on for months, if not multiple years. We saw in Srimai's slide that baseline cost is about 4 to 8 lakh when most of the schemes cover 2.5 lakh to 5 lakh. If you get diagnosed late stage, it's up to 20-25 lakh. So what happens? So we are forcing our, well-trained, well-expert doctors to make a hard decision to how to fit that treatment within the reimbursable limit. So what does it do? It either, compromises the ability to give the right treatment to get the best outcome, or it increases the out-of-pocket expense, which defeats the purpose of having this insurance scheme, right? So I think the time has come now that we're taking basic care of basic needs, we need to move the dialogue for cancer especially, from financial reimbursement limits to coverage based on the standard, uniform protocols, focusing on delivering better outcomes. Now, if you look at, basic things like PET-CT biopsies are not covered in many schemes. Genomic testing, immunotherapy is not covered in any of the scheme, which is where most of the advancement is happening and value addition is coming in terms of improving outcomes. If I have to choose three things, it will be basic diagnosis, which I think is basic, PET-CT biopsies. Definitely panels, disease-specific panels for genomic testing, and then immunotherapy, so that we focus now on improving outcomes and not just giving whatever treatment we can give within the reimbursable limit.
Right. So I think we'll just stretch that thought a bit, and I'll come to Ms. Malti on the similar lines. We've just talked about the cost can be as high as 25 lakhs, and given the fact that a lot of our patients are detected late, these costs are really true costs possibly for a lot of the patients. So the schemes which we have today have it's set by a certain reimbursement limit. What's your view with respect to the fact that should the scheme specifically for cancer, and has the time now come that there is a differential approach chosen for cancer? Should there be a lens of organ? Should there be a lens of stage of detection? And how can that all be factored instead of looking at a blanket coverage of up to 5 lakhs?
Thanks, Srimay. I will first start by quoting some of the points which you mentioned in your original presentation, that when it comes to breast cancer, for example, less than 15% women are detected in stage 1 and 2, right? And then when it comes to screening, even though today we have health and wellness clinics across the country, the awareness around health and wellness clinics is extremely low. And there is a certain amount of morbid fear in the minds of people that they should not go for screening. The moment they go for screening, something will get diagnosed. So I think these are problems that we have today, and therefore today the result is that only 1 to 2% of the population is getting screened. Now why I mention all of this again is because this is adding to a huge financial cost, right? Whereas when we look at some of the other countries, I wanted to do a little bit research around how it's being done in some of the other countries. Korea and Japan have very robust, health insurance programs today. Korea covers to the tune of 95% of cancer cost, and Japan covers almost 75%, right? Even when we go to Australia also covers almost to the tune of 70 to 80% of all hospitalization related costs. And one of the other things which is happening in these countries is that they are being incentivized for outcome and value-based approaches, right? So when I say value and outcome-based approaches, time has come even for us in India to look at the holistic chain, right? From the point in time of screening all the way to outcome and follow-up. If we look at rewarding, our overall system in such a way, people get incentivized for better outcomes, that is what we need to do today, right? We already see Ayushman Bharat progressing in a certain way in terms of, having incentives around accreditation, when it comes to QCI accreditation and all of that. We also see performance-based incentives, what's the kind of re-hospitalization, et cetera, happening. But for cancer today, I think the need for us is to be able to develop a value-based and an outcome-based approach, where we are tracking right from the time of screening, the number of people who visit the hospital from the screening all the way to tracking outcomes. That is when we'll be able to develop a more robust approach towards treating cancer as a disease. That's one point that I want to highlight. Second point that I would want to highlight is, many of these countries are again having compulsory screening. So that's again an approach which we can use in our country as well, whether it's lung cancer screening, colonic cancer screening, breast cancer screening, it's compulsory, for them to get any form of reimbursement. So if that can also be included in our overall, insurance program, that will be extremely beneficial. Another point that I want to highlight is, from an overall making the insurance program more robust is having health technology assessment, which is kind of integrated with our overall insurance program, right? Today, while we do have health technology assessment, it's a bit of cumbersome, so any new technology which is introduced today has the potential to reduce the overall financial burden, right? And at the same time, improve the overall outcomes. We spoke about many therapies, a little while ago, which are not included as part of this. And there are several other modalities which are getting included today, where, today there is ability for us to reduce the overall financial cost and at the same time offer, better outcomes. One of the classic example is breast cancer, where hypofractionation is very beneficial for a specific kind of cancer. And earlier, hypofractionation was not included. And later on, as part of health and financial technology assessment, hypofractionation was included. And what they observed was there was significant reduction in the overall financial cost. And at the same time, you were able to give better outcomes to patients. So I think we need a better integration of the health technology assessment with the overall system. And additionally, I think we need a very robust system to sort of monitor, and audit what's happening in terms of overall outcomes. So today we have a scheme. We are looking at making it more robust for certain areas, like perhaps cancer, where the coverage is insufficient today. So if we are able to really introduce value-based outcomes and not just look at treatment and isolation, but holistically, right from screening to diagnosis to treatment and all the way to follow-up. So that is the approach, as something I would recommend, and this is also one of the best practices for several other countries.
Sure. Thanks, thanks Malti on that. We'll now look at a different lens altogether when it comes to women-specific cancer, and the question is to Dr. Dinesh. We've, I think, talked about the fact today that vaccination is available for HPV-specific cancers, and this is, I think, a very, very widely debated topic which is there, and it's still not been included in the National Immunization Program. What's your view on this specific challenge which still is there in the country with respect to universal adoption of HPV vaccine? And what you believe could be some initiative which could possibly give a fillip or a boost to this, because adoption of the vaccine is a very, very strong preventive measure which can be taken as a government agenda.
Thanks, Shimai, and my fellow panelists. The question on vaccination could be addressed in two ways. Over 50% of the countries in the world have a mandatory vaccination policy when it comes to HPV-led vaccine. What would make the government to step up is not what we went through when we had a pandemic, that it becomes such a large problem that we make it mandatory. The vaccine which is, the Made in India vaccine which is available creates us an accessible program where the cost is much lesser than what it was before. Among most of the countries in the 100 which were mentioned, a few of them which are not even at the LMLC, or probably which have gone through a larger challenge, be it a genocide or being right at the bottom of the pyramid, like Rwanda, has got an 100% vaccination for the women folk. What does the government need to do? Probably the forum here, which is FICCI, and the task force members like Raj, is to talk to the government to see why is India today one of the only countries where 50% of the states do not have cancer as a notifiable disease. I looked at the numbers which was put by Shrima, which says about 1.7 million new cancer cases are diagnosed. To me, that's just the tip of the iceberg, because if 50% of the states are not got cancer as a notifiable disease, the 1.7 could be way off the mark. So one, are you notifying cancer first of all in all the states? Take the largest state in India, which is UP. Cancer is not a notifiable disease. Where you have an election which get cover of a country, the United States, the similar population up north there. Not a single area there has got cancer as a notifiable disease. That large is the problem. So it needs the government to take a decision. 2008 is when ICMR got out a document, a blueprint on why should cancer be a notifiable disease. It's taken close to 2.5 decades to get that notified. In 2022, I had moved a bill at the Rajya Sabha under the Apollo Aegis and got this bill approved. It's now 2 years plus that it still hasn't gotten approval from the Lok Sabha. Cancer as a notifiable disease needs to be a bill passed, made mandatory among every state for you to understand. That's the first step to understanding the burden of the disease and to get data sets which are right. Second, if you have an indigenously made vaccine, you need to step forward to make sure and learn from countries like Rwanda, which have made it mandatory. Giving it a choice as an option will leave people to lose the chance or the option of actually prognosing on a disease later while you're sitting and procrastinating that it is not making sense. The act is to figure out how as bodies like FICCI and the task force can work with government to get this bill out there, to get the bill out for the immunization program. What does it need? It needs a political will. It needs bodies like FICCI, institutions like Apollo, HCG, EY, etc., to come together to push and say, it needs to be done like as of yesterday. And somebody in the government needs to look at the burden of cancer. I'd like to add one more thing, though it's not on vaccination. The global shift on cancer in women is moving away from breast and cervix to breast, lung, and colorectal. Because cervical cancer is a dying disease in most developed countries. When I say a dying disease, the disease doesn't exist anymore because they have done what needs to be done at the right time. That is to create cancer as a notifiable disease and to make sure it is a mandatory vaccination program that today in most developed countries, cervical cancer features 4th or 5th. It's sad to note that only in India, it is almost 56% of the overall cancer in women, and the overall cancer in women is more than 55% of the overall cancer diagnosed in India. So a political will through bodies is a must. Thank you.
Thank you, Dr. Dinesh, on that. I'd like to now move on to Praveen. And Praveen, we'll touch upon the question with respect to screening. We saw that screening penetration, although breast and cervical are the two identified disease for screening, but the penetration is, a mere 1.5%. And we've also, I think, seen through a lot of studies that the awareness about screening itself is also low. It's low not only among the population in general, it's even low among the healthcare participants in terms of nurses, in terms of ASHA workers, etc. Even they are the ones who are supposed to deliver the screening, but they themselves are not practicing screening on themselves. So that is the state of screening in the country at this point of time. So what is your view on what are some of the interventions which the government needs to take to increase the penetration? The program is there, the penetration is low, it's not adopted well. What now needs to happen differently as an initiative by the government to drive this?
Thank you, Shrima. And though I was just reflecting on the comments made earlier by Raj and Malti and others, though we haven't compared notes, I actually agree with a lot of them. And I guess as somebody said, you can't stop an idea whose time has come. So maybe the time has come for some of these ideas to really get traction. So maybe I'll structure my answer into 3 parts. The first is, okay, what's a good benchmark? So what's a good screening rate, right, that we know? Second, what have we learned when you look across the globe on what actually works in terms of increasing screening rates? And 3, what does that mean for what we could do in India? So when you look at the benchmark, right, like the WHO says 70% is something that you should really try to aspire for. When you look at the US, it is, based on the age, 60 to 80%, so they're clearly there. But what's more interesting is that when you look at something like Brazil, which I tend to find to be a good sort of a country that we can maybe pick some learnings from because it is a developing market, huge, very diverse. There it is about 20 to 30%. So they've gotten there. And then we say, okay, what tends to work in the context of driving screening? Now, one of the things that I'm a little skeptical about is saying that just doing awareness campaigns works. Actually, I haven't seen that work in many of the sort of instances where we invest in it. What tends to work better is actually when you catch somebody who comes for something else, but are eligible for screening to be screened, or at least to be initiated down the path to be screened. So what does that mean? Like most people, like if you say, okay, go get screened for breast cancer or lung cancer, you have a lot of reasons why you don't get to that, right? Because you're busy, there is a taboo, all kinds of things. But if you go to your primary care physician or get some health care because you've got cough and flu, which is an acute thing that you're going there for, but then they say, look, you should be screened because you're in that age group where you should have breast cancer screening. That tends to work much better because you're capturing somebody who's already coming into the healthcare system for a different reason, rather than asking them to go into the system to be screened. The second thing that tends to work is that you have to incent the healthcare workers to actually drive screening, right? So for example, in the US, you go to a primary care physician, you're over 50 and you're eligible for breast screening, they don't get reimbursed unless they've actually talked to you about screening and have sort of initiated you down the path. So what can we do to actually sort of put that incentive to drive screening? And the third thing is that, and this is more sort of a tactical element, what tends to work is when you have a human and a technological intervention work together. So one of the things that's been proven over and over again is that patient navigators work really well in terms of driving up screening rates. That's because they actually follow up. And when they can follow up, especially with the aid of a technology, with reminders and stuff, it's proven to like double the screening rates when you look across different parts. So that's what we learn. We've learned when you look at examples of what's worked, then we say, okay, what does that mean for what we do here, right? And given all the conversations about PMJAY and Ayushman Bharat, maybe a first step to look at is how do you build on the infrastructure that already exists? So if you've got a health and wellness center, can we really make this a priority and incent the folks within that ecosystem to drive it when, for example, a woman comes in because she's got flu, but she is really eligible to be screened? Can you have that counseling and put her, get her to an appointment to get screened, right? So can we initiate that? And then leverage ASHA workers, for example, as that patient navigator sort of follow-up that you can really prioritize as part of screening. So these are maybe a couple of elements. Now, one other comment I'll make, and then maybe we can come to this later on, is that one of the big things that we have to think about is that screening is only useful when you can actually get access to treatment if you're screened. The worst thing that you can do is screen somebody and you actually have no access to treatment. Then all you've done is increase their anxiety levels, but haven't actually helped them. So one of the things that we have to think about, and I think, Raj, that's why I really appreciate what you've said, is that you have to think about it holistically to say, okay, you've screened, great, first step, but it doesn't stop there. You have to then say, have you diagnosed them properly? Do they have access to NGS testing, for example? And then if they are actually diagnosed, do they have access to treatment? And only then screening actually works. Otherwise, it's very incomplete.
Got it. Maybe I'll just extend the conversation with you, Praveen, and we'll talk about another topic which is linked back to treatment. And we talk about medical oncology. I think we saw that almost 40 to 60% of the entire portfolio of treatment actually is attributed to medical oncology. And today we have access to oral cancer therapies, targeted therapies, immunotherapy, all of that. However, we do see that we talked about the health technology assessment being an important criteria, but the pace at which a lot of this adoption is actually happening within the government schemes, the reimbursement policies, in some cases even by the private insurance companies, is relatively much slower. Again, what differentially can be done? What's the intervention which is required to fast pace this a bit? And also, secondly, are these not adequately backed up by clinical trials done in the Indian context? And what is the hesitancy which is there from the government side to take up some of these kind of modern treatments?
So maybe I'll start with the second part first. At least to my knowledge, I think what we do see is that there's an increasing representation of patients from India in most of the global clinical trials. I know that's true in what we do from our organization, and I'm sure it's true for most others. But of course, that is always a consideration because you do want to ensure that you've got evidence that is relevant to the population you're treating. So that's a good thing. The second part to what you're saying, I think Raj already touched on it, which is that maybe a clear opportunity that we have is that, it's great, and I really want to applaud all the efforts across the government and society here in terms of getting that basic sort of safety net, right, in terms of health assurance and insurance. So that's great, but what is clear is that in the context of cancer, it's not enough. It's a good first step, but it's clearly not enough. And maybe what we can really focus our efforts on is, can you top that up? Like, and you shared the data in terms of the cost of these cancer treatments. Now, the good thing is that a lot of these treatments are actually really effective. So I would be confident that in many ways, the cost effectiveness is probably something that we can continue to look at, but they do work. So how do you make them more accessible? And so is there an opportunity for us to top up like the basic assurance with maybe 4 times, like from 5 to 20 lakhs for cancer patients? Now, this is something that we've actually seen, and it works. Like, for example, in Philippines, that's what happens, is that you've got the basic health insurance, and then for some disease areas, it's 4 or 3 or 4 times. And they have seen that to be quite effective. So maybe that is something that we can look at as well in India, and maybe that's very actionable. And what we're seeing is that whenever we discuss that, there is quite a bit of, I think, energy behind trying to do something like that.
Sure. Thank you. I'd like to now move on to Mr. Shankar. And I think for you, the question, sir, is that we talked about this data point of lack of access to comprehensive cancer treatment across the country, not more than 175 districts having that. And I think one of the key pillars to make cancer care comprehensive is the access to radiation setups. So what's your view in terms of some of the solutions which can help increase access to radiation therapy? And also specifically the fact that given that it's a heavy capital cost involvement when it comes to putting up these kind of setups, are there today more options which are available as we look at expansion to tier 2, 3, 4 kind of cities, which are actually more capex cost effective? And again, how do you think that the reimbursement structure which the government has towards radiation therapy, are they all working in tandem to make this access possible?
Thank you, Shrimi. I think you had asked about 3 questions, so let me take the first one. How do we improve radiation therapy access across? Worldwide, if you look at radiation therapy, about 50 to 70% of the people have access to RT, whereas in India, currently, if you look at the Lancet journals data published, only about 30 to 35%, or at best 40% of the people have access to radiation therapy. So that's still a significant number of people don't even have access to radiation therapy, though they do come over for cancer treatment. So that's something which we first need to work on. But how do we improve that awareness? One, of course, is straight away getting into infrastructure. So you get into all the 700 districts or 800 districts of India to put a LINAC across to get them access to there. But that's only a smaller problem to confound, in my opinion, because even if you have centers which have infrastructure, we do find that they don't still have skilled staff, adequate amount of manpower to handle them. So what as an organization we do is, so specifically if you talk of the women's cancer, breast cancer, cervical, we are partnering with important RT centers to educate people of how to skill them better and enhance their capabilities in a way that you get better patient outcomes, etc. Malti touched a very important point. There was an article in Lancet published in, and it was discussed extensively in the Astro Congress about 2-3 months back. The use of SBRT is still only about 15 to 20% in India. And that, if probably gets a much higher enhancement of usage of SBRT, what it could, and there's the study says prostrate and cervical breast, you can bring down the fractionation to as low as 2 fractions or 1 fraction. What that would mean is free up the available resources in many hospitals to be available for treatment of other patients, other types of cancers. But to embrace that, you need to have skill again coming up. So it's very important for private organization like us to partner with people to see how we can help improve this case. We have Brachy academies in India where we do educate, partner with the key centers to help RTs to skill themselves in brachy. And you see, for women's cancer, brachy is a very important means of treatment. But overall, worldwide, that's something which is coming down, not purely because of affordability, it's also because of Western world feel that, like Dinesh said, cervical cancer is almost eliminated in most of the big countries. But there's a huge scope available still in LMIC countries, where teaching them how to use brachytherapy, a good skilled radiation oncologist who can do well in brachytherapy actually will mean a better outcome for the patient. So that's to address on awareness. I just want to touch base on one of the very novel methodologies being used in Chennai. There is an NGO which actually does this, something which is good to emulate. They go after schools. They meet all the children in the schools. They actually talk to them, ask them to bring the parents for screening. And probably some kind of a motivation is being done in schools. And because of this, I've seen many young parents at 25 to 35 age group parents getting screened. And this is something which probably can be used across as one of the probably methodologies of improving an awareness, etc. The other point you brought in again was whether the government reimbursement schemes are working in tandem. I think still today a large number of schemes in government, if you see, are giving majority for treatments like IGRT, IMRT. You did show in your journal that greater than 20 fractions are being paid a certain amount, in IMRT 30 fractions. That still comes as a criteria for treatment in cancer centers. But if they start differentiating that and educate, say, SBRT treatments are probably paid higher, more and more hospitals will actually come up in performing them. I know of many hospitals today only handle IGRT, IMRT, only the big centers, probably like Apollo, HCG kind of centers, do a lot of SBRT. I think we should encourage them, and for that the government must come out with schemes to pay a higher amount of reimbursements to the patients so that this treatment starts becoming more and more prevalent. What that would mean is making the life of the patient becomes much better. Second, you also free up the existing resources to be better accessed. So you can probably run from 2 shifts to 2.5 shifts or 3 shifts, etc. There are many centers across today, out of about 700 different RT centers, probably only about 100 or 150 are running to certain capacities. There are a lot of other centers, while we talk of huge gap, there are a lot of centers which actually don't do more than 30, 40 patients, have a lot of availability with them. So we are not even harnessing that part of it, while on one side we talk of gap and improving. So this is something which government can really work on, and in order to make sure that more and more people are embracing hyperfractionation to free things up.
Great. I think that brings us to the end of the panel discussion. If there are any questions from the audience, we could possibly take that.
I'm Dr. Raja. I'm a postdoc working on cancer and mesothelioma. My question is a little off the topic. It's about notification of cancer in India. 16 states out of the 28 have made cancer a notifiable disease, and at the center level, the ministry has not made cancer notifiable. So how does notification play a role? Will it help the whole cancer scenario across the spectrum in India? What are the views of the panel?
So if you look at the West, the first thing is to identify and recognize the problem. How do you identify is first you create a set of data points to actually figure out if you die of something, or if you're diagnosed with something, or if you have a family history or a genetic predisposition, how do you actually document this? For people to understand the quantum from a problem perspective. Next is to find out what could be a policy guideline. We have a panel here from various organizations. In the August gathering, I'm sure people are there from various institutions which represent healthcare. Are we following a single uniform code of what is called a guideline for cancer in women? The answer is no. So whether it's a government policy to ensure notification, to raise awareness, to quantify the problem or the data set, or to do the discipline of actually providing treatment, there is nothing being implemented. Even in the 15 states, it's actually 16 out of the 28, though it's notified, who's ensuring that every case is mandatorily being documented? It's a big question mark. The second part of your question, how is it going to help? To me, if we get to know really how big the problem is, we get to know classification of it from a demographic perspective, we get to know from a social strategic strata perspective, we'll be able to address it. Otherwise, like my fellow panelist Praveen said, you'll create a lot of awareness without actually figuring out how to execute post-awareness.
On the notify, I just want to highlight something is that don't talk about the West. In India also, if you look at tuberculosis, any tuberculosis that comes in, whether it's in the private sector or the public sector, we notify it to the district health authorities. Because I, as the chief medical officer of the company, anything that comes up, any of the hospitals, I get a notification from this hospital that we have sent it to the. So what I'm saying is that when it goes to the district medical officer, because the district medical officer is the head of the medical services for that district, so they can trace back, because the DOT program that has happened, so you can go to that patient, the house, check whether that patient has got the taking the medicines, and follow up. So the basic purpose of this notification is that if it becomes pan-India, then tracking back to see that have they been diagnosed, have they been treated, are they following up on the treatment? Because a lot of times there's a gap in the treatment, and that's the worst thing to happen.
They're not notifying cancer is because it's not a contagious disease at the central pan-India level. But it's almost an epidemic scale in India if you really look at the numbers. But so how do you answer that? Because TB and all, they say it's contagious, so we'll notify it.
Cancer roundtable that happened across the country, the recommendation of the government is to make it a notifiable disease. Like just I gave the example of tuberculosis, something similar. Like if you have dengue, any hospital, whether it's private or sector, public sector, they have to inform the medical officer of that district. So unless this happens, we will not be able to know the incidence. So what is the disease prevalence of the different cancers? How do you plan it? So this is something that has to happen now.
Just add on there. So we are living in the past. If you are talking that we need to only address issues which are communicable, we are living a world of NCDs, which is the larger problem. Non-communicable disease is the problem of today, which is contemporary to what's going to happen in the future. What we're talking about is a classic example if you're talking tuberculosis. The reason today tuberculosis is moving to a total eradication is the fact that it's been identified, it's been notified, and you have a process around it. Stating that we should do it only for contagious disease is probably not looking at adoptions done in more developed countries on why they haven't looked at it as only contagious and looked at the growing, burgeoning problem of NCDs. And today, when you look at cancer and you look at a non-communicable disease, other than one which is probably a Kaposi sarcoma, everything else comes in a classification NCD, and that's the biggest problem. And that's going to be the biggest burden.
Thank you.
I think we will have to wrap up the session now. Maybe we can, maybe one question from your end.
Okay, thank you very much for that. So I think some excellent points were made, but there wasn't anything that was touched upon on digitization or using or leveraging digitization to solve the access problem or what's happening today. So collectively, there's a lot of experience on the stage. So is there something that we can emulate as a country that you've seen in another country where digitization actually paves the way for tackling some of these problems?
Karan, if I may answer this, as part of the Quad initiative that India, Australia, Japan, US is doing, our organization, you must be aware, they are already working with the Quad organization in order to enable remote protocols and workflows by enabling cloud-based access to the various RTs in countries like Australia, etc., to use those resources from a planning perspective, segmentation perspective, in order to give a better patient outcome. So digitization is definitely a significant way forward.
Yeah, I just want to say digitization is given, and especially when it comes to addressing capability issues. You know, when you go to tier 2 and tier 3 towns, you don't have that level of capability. So all these remote solutions, cloud-based solutions that he spoke about is a great way to, you know, address capability issues. So digitization will definitely go hand in hand with creating a better access in the country.
Thank you, esteemed panelists, for your contributions today. So we come to the close of the session.
Thank you. Thank you very much, Madam, and the convener and the esteemed panelist. It was indeed a great discussion. And if you guys don't give a harsh look at me, I would like to declare that we do not have a tea break. We are moving towards the 11th session, which is synergizing healthcare proficiencies through interdisciplinary education.